This recording will go over venous insufficiency and varicose veins. Venous insufficiency occurs as a result of prolonged venous hypertension that stretches the veins and damages the valve. Valvular damage can lead to a backup of blood and further venous hypertension, resulting in edema and decreased tissue perfusion. With time, this stasis results in venous stasis ulcers, swelling, and cellulitis. Venous hypertension can occur in people who stand or sit in one position for long periods. Obesity can cause chronically distended veins, which lead to damaged valves. Thrombus formation can contribute to valve destruction. Chronic venous insufficiency often occurs in patients who have developed thrombophlebitis. In severe cases, venous ulcers develop. Venous insufficiency may result in edema of both legs. There may be stasis dermatitis or a reddish-brown discoloration along the ankles extending up to the calf. In people with long-term venous insufficiency, stasis ulcers often form. They can result from the edema or from minor injury to the limb. Ulcers typically occur over the malleolus, more often medially on the inner ankle than laterally in the outer ankle. The ulcer usually has irregular borders. Please review chart 36-4 to compare venous ulcers to arterial ulcers. Some people live with ulcers for years, and recurrence is common. Some may lose one or both legs if ulcers are not controlled. The focus of treating venous insufficiency is to decrease edema and promote venous return from the affected leg. Patients with chronic venous insufficiency wear graduated compression stockings, which fit from the middle of the foot to just below the knee or to the thigh. Stockings should be worn during the day and evening. Explain the purpose and importance of wearing the compression stockings. Be sure to use a sizing chart that comes with the stockings to select the best fit. Teach patients not to roll them down and to report if they become too tight or uncomfortable. Teach the patient to elevate his or her legs at least 20 minutes 4 or 5 times per day. When the patient is in bed, remind him or her to elevate the legs above the level of the heart. Coordinate with the healthcare provider about the use of intermittent sequential pneumatic compression or foot plexus pumps for patients with past or present venous stasis ulcers. If an open venous ulcer is present, the device may be worn over a dressing such as an Uniboot. Instruct the patient to apply the pump as directed during the period of healing. Two types of occlusive dressings are used for venous stasis ulcers: oxygen permeable dressings and oxygen impermeable dressings. Because the role of atmospheric oxygen in wound healing is controversial, options vary with regard to which type of dressing is preferred. Artificial skin products can be used for difficult to heal venous leg ulcers. If the patient is ambulatory, an Uniboot may be used. An Uniboot dressing is constructed of gauze that has been moistened with zinc oxide. Apply the boot to the affected limb from toes to knee after the ulcer has been cleaned with normal saline solution. It is then covered with an elastic wrap and hardens like a cast. This promotes venous return and prevents stasis. The Uniboot also forms a sterile environment for the ulcer. The healthcare provider changes the boot about once per week. Instruct the patient to report increased pain, which indicates the boot may be too tight. The provider may prescribe topical agents to chemically debride the ulcer, eliminating necrotic tissue and promoting healing. If an infection or cellulitis develops, systemic antibiotics are necessary. Surgery for chronic venous insufficiency is not usually performed because it is not successful. Attempts of transplanting vein valves have had limited success. Surgical debridement of venous ulcers is similar to that performed for arterial ulcers. Please review chart 36-9, which contains patient and family education for venous insufficiency. Varicose veins are distended, protruding veins that appear darkened and tortuous. They can occur in anyone, but they appear common in adults older than 30 years old whose occupations require prolonged standing and heavy physical activity. As the vein wall weakens and dilates, venous pressure increases and the valves become incompetent, causing venous reflux. The incompetent valve enhances the vessel dilation and the vessels become tortuous and distended. The overall purpose of management for patients with varicose veins is to improve and maintain optimal venous return to the heart and prevent disease progression. Conservative measures are the treatment of choice, including the 3 E's: elastic compression hose, exercise, and elevation. Graduated compression stockings rely on graduated external pressure to improve venous return by applying pressure to the muscles. Exercise increases venous return by helping the muscles pump blood back to the heart. Teach patients to avoid high-impact exercises such as horseback riding and running. Daily walks and ankle flexion exercises while sitting are common exercises that are helpful in promoting circulation. Elevating the extremities as much as possible allows gravity to work with the valves in promoting venous return and prevent reflux. Patients who continue to have pain or unsightly veins despite using the 3 E's may opt for more invasive approaches. Surgical ligation and/or removal of veins were the procedures of choice for many years. Sclerotherapy to occlude the affected vessel is also an option. However, newer, less invasive treatment are more common today. They are less painful and have shorter recovery time. A common procedure is the endovenous ablation, which occludes the varicose vein. Using ultrasound guidance, the clinician advances a catheter into the vein and injects an anesthetic agent. Then the vessel is ablated or occluded while the catheter is slowly removed. After the procedure, teach the patient the importance of using a graduated compression stocking or other form of compression for 24 hours a day except for showers for at least the first week. Follow-up ultrasound ensures that the treated vein is closed. The patient is monitored carefully for the first 6 to 8 weeks to determine how healing has progressed. Assess the affected limb for vascular stasis, including any changes in color or temperature. Monitor for pain, edema, and paresthesias that could indicate complications such as DVT or nerve damage. Nerve damage is usually temporary or minimal. It usually resolves within a few months. Please review the case study questions and end of PowerPoint questions. Pause the video, read through them, pick out your answer, and then resume the video to find out if you are correct. For case study question 1, the correct answer is this patient has several risk factors for hypertension, including his age, being African American, having a positive family history for high blood pressure and diabetes, smoking, being overweight, and having job-related stress. The correct answer is the patient's blood pressure indicates he may have hypertension. However, blood pressure should be checked in both arms and 2 or more readings should be taken over at each visit, with the average of the readings used as the value of the visit. The correct answers are B, D, and E. The correct answer is B. The correct answer is B. The correct answer is B. The correct answer is D, as in dog.